So is Christian Stoppe connected? Ah, okay.
Yes.
Hi, Christian. Hi, how are you?
Hey, good to see you. I am pretty good. Yeah, thank you for having me. It's a big pleasure to be at least virtually here, although I would have preferred to be there in person. So my sincerest apologies, and thank you.
Thank you. So Christian Stoppe is an intensivist in Germany, very much do a lot of research on nutrition. So we're going to listen to him about the nutrition in cardiac surgery. Thank you.
All right. So I'm going to share my screen. So let me do full screen. So can you see my full screen? Yeah.
Yes.
Okay. Thank you. All right. So yeah. So it's my pleasure right now to talk about one of the. After we have talked about the single components, to talk about one of the, from my perspective, most under-recognized aspect within the perioperative care. It is just the nutrition support in our patients, and I will lead you through all of this by talking about the preoperative phase, the intraoperative phase, and the postoperative phase, because within all of these windows, we have specific problems and strategies how to overcome these problems from the nutritional perspective. And I thank Seda very much for outlining the relevance of malnutrition in this patient, which is one of the really significant problems which we more and more consider. So let's start with the preoperative phase. So we know that the nutritional status of our patient, but as well the reduced oral intake in our patients, especially in the elderly patients, is of high relevance. And starvation is another problem because surgical procedures are rescheduled from day to day or to the next week, etc., leading to a significant starvation in our patients. And we have to critically ask ourselves if we can expect that really all patients has the same nutritional risk and all patients benefit from our nutrition intervention. And to do a rigorous risk stratification with respect to the nutritional risk is actually recommended by the different nutrition guidelines, the American guidelines, European guidelines. We have our own guidelines in Germany. So, and then all of them uniformly recommend that a nutritional risk stratification should be done. And even the ISHLT is giving a recommendation for that. And when looking into what is already established in the more general surgical patients, we know that there exist already like well-established pathways. So when you know which are established in the clinical practice, so when you identify patients who are malnourished, such patients should be scheduled. So the surgery should be rescheduled, and a preoperative optimization program should be done in these patients. And the nutritional assessment is very easy. It's basically it basically considers the BMI, the unplanned weight loss, and as well the albumin level, which we see more and more in different risk scores, although I'm very critical about that. It's just a fact. And when we have once identified patients at risk, it's recommended to reschedule the surgery and to schedule a preoperative optimization program. So what is known for cardiac surgical patients? So when regarding our existing guidelines or recommendations for cardiac surgical patients, a preoperative measurement of albumin for risk stratification is recommended, although all of this is based on a rather moderate level of evidence due to not really strong large-scale RCTs in this area. A preoperative correction for nutritional deficiency is recommended and should be done whenever feasible. And a preoperative carbohydrate loading is as well recommended, which is based at the moment on a low level of evidence, and certainly more evidence is in this area needed. And we try as well to contribute to this level of evidence, and we are not focusing here on the all-day patients like the bed and breakfast patient who just stay one day on the ICU. We here in our studies, for example, focus on a specific vulnerable patient cohort, such patients that are scheduled to receive an LVAD implant, because here we can do the preoperative optimization strategy in patients who are already in the hospital. And this is a patient cohort that has a high likelihood to benefit from a nutritional intervention. And then we hope to learn from these patients and to transfer the learnings back to the more general population. So what is known from the intraoperative phase, from the nutritional perspective, inflammation, ischemia perfusion, the surgical trauma can eventually be attenuated by immune modulating agents and micronutrients. And we know that the inflammatory response is a major driver which contributes to the development of organ dysfunctions that necessitates a prolonged ICU length of stay. So for that reason, a lot of little pilot trials, smaller trials, investigated different anti-inflammatory and antioxidative strategies. And as such, we as well recently published a large-scale RCT, which was conducted in Canada and in Europe. So hello to John, by the way. And as such, we randomly assigned patients where we thought that they were at high risk or increased risk for postoperative complications to receive preoperatively a loading dose of an anti-inflammatory strategy. Here was a high-dose sodium selenide administration, followed by a high-dose sodium selenide administration, which was continued after surgery and while the patient was on the ICU. However, the primary endpoint was very disappointing. When we received, like 5 years later, the overall results that we received from over 1,400 patients, then the primary endpoint, the freedom, so the ICU dependency, did not differ between these patients. So this was a composite endpoint that with persistence, the composite endpoint called persistence of organ dysfunctions within 30 days, and it was very sensitive. And we failed to demonstrate a clinically meaningful benefit in these patients. Eventually, there was an effect when considering the early perioperative phase, because patients that received the high-dose selenium supplementation had less organ injuries during the very acute phase after surgery, but this effect disappeared over time. As well, the secondary endpoints were not encouraging or did not identify some promising effects in these patients, whereas the subgroup analysis at least indicated that patients that were frail or such patients that had really a prolonged CVV time eventually showed a tendency to favor more from the high-dose selenium supplementation. So why did this happen? We are currently doing a lot of subgroup, secondary analysis, post-hoc analysis to get more answers about that, because we do just want to continue. And one of the answers which I would like to share with you is the answer about like which patients belong to the vulnerable patients, which patients should be on our focus. And as such, I'm happy to share this unpublished post-hoc analysis that identified the patients that were elderly, that showed signals of frailty, so which had urgent surgeries and which had a higher Euroscore or in the end prolonged CVV time, that these were identified as a high-risk population, which we know as well from other data. But even when combining at least two of these factors, we received a very good predictive accuracy for the development of organ dysfunctions and death during the ICU length of stay after surgery. So we want to take these learnings right now, and I'm very happy to be in contact as well with Professor Gunaydin about that, to eventually test following next compelling anti-inflammatory strategies in these patients to contribute to the resolution of inflammation, because we know that inflammation per se is important for our patients. We don't want to block it per se. We just want to modulate the perioperative inflammatory response in our patients. So let's talk about the postoperative phase, when our patients are admitted on the ICU. So what do we know about nutrition practice? We recently published the results of an international nutrition survey, an observational study, which was conducted at cardiac surgical ICUs worldwide, and the nutritional data and outcome data were captured inpatients and cardiac ICUs from Canada, the US, Germany, Russia, Iran, Malaysia participated in these observational studies, and we assess the nutrition practice on the ICU in these patients. And this is really a highlight which I have to share with you. So the blue dotted line demonstrates here so this picture demonstrates the adequacy of energy input, and the dotted line indicates the target goal for nutrition. So the nutrition targets which should be achieved based on current guideline recommendations. On average, this is the blue line, the patients received with significant delay the recommended nutrition targets, whereas the worst side, it's a red line, never ever nearly achieved the nutrition targets, whereas on the other hand, the black line demonstrates that achieving nutrition targets is doable. And the problem is, if we do not achieve our nutrition targets, it leads to significant deficiencies, that leads to a significant loss of muscle mass in our patients, that in the end influence the functional recovery in our patients. So when patients are discharged from the ICU, we have to think more, not only about the survival in our patients, we have to think more about the quality of life in our patients and the functional recovery in our patients. And the same holds true as well for the protein target. There were significant deficiencies illuminated in our patients, so there exists a knowledge gap in nutrition practice, which we have to improve. So what are the reasons for that? And I just briefly want to touch on this. So the timing for initiation of enteral feeding, for example, showed a high variance across sites. So on average, EN was started after 2 days. So whereas it's recommended to be started within 24 to 48 hours in the general ICU patient when the patient is hemodynamic stable. The other reasons were that a lot of interruptions were observed in these patients. And this is what we all know as clinicians, which is happening. So we are reluctant to ramp up enteral feeding, or when the patient is on high dose vasopressors, we are reluctant to be too aggressive with our enteral feedings, but we do not have strategies to compensate the potential resulting deficiencies. So, and sometimes there's a CT scan planned in the morning, the feeding is stopped, but the CT scan is happening in the afternoon. And we never think about how to compensate the resulting deficiencies in our patients. So potential strategies to overcome that is to think more about the timing, as briefly outlined before, and as well to think about strategies like the use of supplemental parental nutrition as a combined strategies to avoid such deficiencies. So when you want to rather protect the gut, you are anxious about some complications in these patients, which, by the way, are not really objectified when looking at the literature, you can think about the use of supplemental parental nutrition to avoid the potential deficiencies. So how to bring all of this together? So for your clinical practice, for your patients at home. So here, this infographic illustrates the early phase after admission to the ICU, 24 to 48 hours, and the post-acute phase. We know that the hemodynamic instability, the surgical procedures and interventions leads to a lot of interruptions when considering the feeding strategies in our patients. And here, the first point is certainly that we have to be aware of that. We have to think and look back at our patients yesterday achieve our nutrition goals, which we have set. So have we do something to improve that? We have to focus on the right patients. So does our patient has potentially a prolonged ICU length of stay, so more than 1 day? So then he or she is certainly a high-risk patient, so which should receive an intense nutrition support. We have as well to think about if a patient is extubated, or about a reduced oral intake or appetite in our patients, or about dysphagia, which is relevant as well in the elderly patients. And then we have as well to think about the critical illness in our patients. So when our patient is on high dose vasopressor, has signs of inflammation, etc., it's maybe really not the time to achieve full nutrition support. but this is the only contraindication in your patients. And then think about really, how can you optimize your feeding? How can you really achieve your nutrition targets, which you have set the day before in your patients? And if all of this doesn't work, think about the concept of supplemental permanent nutrition to avoid the potential deficiencies. And then the last point is exercise. If you think about the people who are going to the gym, or else they do not just go to the gym and drink the protein shakes, they do exercise and are drinking the protein shakes to really try to contribute to the gain of muscle mass, or here in our patients, to prevent the loss of muscle mass. And we can only achieve this goal if we combine nutrition support with exercise in our patients. And then the last point is monitor the success of your intervention. And it's very easy to do that. Think more about potential outcome measures, which your physiotherapists are eventually already doing, like the hand grip strength, the 6-minute walk test. There exists a battery of different things which you can easily implement in your daily practice, either in the intubated or in the extubated patients. Happy to share more information about that. And in the end, it's really important to add more quality to the life in our patients. We have overcome the phase where we were just focusing on the survival. Now we are really focusing more and more on the functional recovery, the quality of life in our patients. And by focusing on the nutrition support and exercise, I hope that we can do a significant contribution. And as such, we are as well doing a lot of research in this area. We are planning a new trial to focus on nutrition support and exercise, which will evaluate the functional recovery in our patients. And I'm happy to share as well that the ERAS Cardiac is partnering with international societies to establish new guidelines for perioperative nutrition support in cardiac surgical patients. I'm happy to receive any people who are interested in this topic to talk offline about that. And the last point is really that we have as well to focus on other patient populations, such with MCS support, in which this is certainly a risk group where we are more reluctant to think about nutrition support. It's really happening after patient is days on the ICU. And we as well try to give more guidance about how nutrition support should look like in these patients. And with this, I'm at the end of my presentation. With this little illustration, I just want to make clear that there exist a lot of gaps during the journey of our patients. So when the patient is admitted to the ICU, there are a lot of risks for when malnutrition may happen in our patients. So nutrition risk is a modifiable risk factor. So it's very easy to address that, to be aware of that, and to with the nutrition support, we can really improve our patients' outcome. And we have to monitor the nutrition intake. We have to give guidance and feedback, and really focus more on this. And with this, I'm at the end of my presentation and very happy to take your questions.
I'm here with Dr. Nalbanti, intensivist from Greece. So she may be asking questions.
Hello. Thank you for the presentation. I don't want to make a question. I want to highlight 2 points about the use of supplements like selenium and the energy drinking or high carbohydrate drinks before 2 hours prior to surgery. I think that this is the difference about all that we know until now. Can you explain your everyday management of the patients there?
Yeah, so 2 points. We have problems with clinical trials in this time. Yeah, so like it's really hard to find any trial, any intervention, although I'm really very enthusiastic about research. It's really challenging to show that any intervention results in a clinical significant effect in large-scale RCTs. So this when I'm telling you that the results were neutral, it is not the conclusion that the intervention doesn't work. It's really about we have to identify patients that may benefit from our patient. So when Professor Gunaydin is doing a risk stratification, he identifies patient with a nutritional risk, then this is a target population which should certainly receive the carbohydrate loading, the protein drinks, etc. You need to establish the standards to identify the patients and to start the nutrition drinks. The other point is, if you have, for example, a patient where you know this will have a prolonged time on this cardiopulmonary bypass, then you could think about the oxidative stress which is happening. So I cannot give you recommendations about that, but I know that a lot of patients, clinicians, and especially anesthesiologists care about that. How to attenuate the inflammatory response, how to attenuate the resulting oxidative stress, and here micronutrients, antioxidants might be a potential strategy in the future. Yeah. They are actually doing this. Yeah.
Thank you.
Thank you very much, Christian. Thank you for the presentation.
Thank you.